Okay, so now we're going to start with our physical examination of the respiratory distress patient. Your physical exam of the patient with respiratory problems should continue the evaluation of his airway, breathing, and circulation you begun during your ABCs. You will use the physical examination techniques of inspection, auscultation, and palpation to evaluate the injury or illness in more detail. Um, let's start with inspection. Begin the physical assessment by inspecting the patient. Evaluate the adequacy of his breathing. You're using your eyes. You're looking at the patient. You're looking at their chest. You're looking at their uh, head, chest, skin. You know, you can tell all this. You can tell a lot just by looking at a patient. Always assess the skin color as an indicator of oxygenation status. Um, Look for any obvious signs of trauma. Early in respiratory compromise, the sympathetic nervous system will be stimulated to help offset the lack of oxygen. When this happens, the skin will often appear pale and diaphoretic. They uh, they'll lose color. They'll kind of get sweaty or cool and clammy. Um, when this happens, the skin will often appear pale and diaphoretic. You'll note cyanosis, the bluish color, is another sign of respiratory distress. When the oxygen binds with the hemoglobin, the blood appears bright red. Deoxygenated blood or deoxygenated hemoglobin, however, uh, is blue and gives the skin a bluish tint. Uh, this is not a reliable indicator. Several tissue, or I'm sorry, severe tissue hypoxia is possible without cyanosis. In fact, cyanosis is considered a very late sign of respiratory compromise. When it does appear, it usually affects the lips, fingernails, and skin. Not so much the fingernails themselves, but the skin underneath them or the nail beds. A red skin rash, especially accompanied by hives, may indicate an allergic reaction. A cherry red skin discoloration may, on rare occasions, be associated with carbon monoxide poisoning. And as we're entering into the winter months, that is one thing that is very possible as the heaters are fired up for the first time in several months. And then with the Midwest, like we are, where we swing from 80 degrees in the afternoon to 30 degrees at night, we're not sure what to turn on, the air conditioner or the heater. That severe temperature swing can actually crack the heat exchangers within your furnace and allow the carbon monoxide to come out through those cracks and into the air that you're circulating in your home. That's why they recommend the carbon monoxide detectors in the houses. And that's why we see a unusual, I shouldn't say unusual, but a spike in carbon monoxide poisonings in the fall months. Um, there can also be, in rare occasions, can also cause bullae or large blisters on the skin. I personally have never seen this. Observe the patient's position. Are they in the tripod position? You know, they're sitting down, leaning forward, one or both arms down on the knees to stabilize the body. This would indicate things like COPD or asthma exacerbation. They're trying to expand that chest as much as they can. Their back is straight. They're leaning forward. They're supporting themselves. Um, it's We call this orthopnea. Increased difficulty while laying down may indicate congestive heart failure or asthma. Next, you want to inspect for dyspnea. Abnormal breathing rate, pattern, or effort is essential. Dyspnea may cause or be caused by hypoxia. Prolonged dyspnea without successful intervention can lead to anoxia, or the absence or near absence of oxygen, which without intervention is premorbid, basically occurring just before death. Uh, as the brain can only survive 4 to 6 minutes in this state, remember that interventions are useless if you don't establish a patent airway. So if their airway is not patent and you throw oxygen at them, the oxygen ain't going to go nowhere because the airway is occluded or partially occluded enough to create this state. We also want to observe for the following forms of respiration. Coughing, the forceful exhalation of a large volume of air from the lungs. It is a protective function, remember, for expelling foreign material from the lungs and airways. Sneezing is a sudden forceful exhalation from the nose, is usually caused by a nasal irritation, allergens, dirt, dust, pollen, multiple things there. Hiccuping, sudden inspiration caused by spasmodic contractions of the diaphragm with spastic closures of the glottis. It serves no known physiologic purpose. However, it has been theorized that it is late in evolution or early in evolution. We had gills, and this is something they think may be held over from that time. It's all theory, but it's something you may see if you expand your reading into other areas. Has occasionally been associated with acute myocardial infarctions and on the inferior surface of the heart, so down near the diaphragm, at the apex of the heart. Sighing is a low or a slow, deep, involuntary inspiration followed by a prolonged expiration. It hyperinflates the lungs and re-expands atelectic alveoli, so alveoli that have collapsed. This helps to expand that. And this normally occurs about once a minute. And we're also going to possibly see grunting, a forceful expiration that occurs against a partially closed epiglottis, usually indication of respiratory distress. This is especially true in infants. If you hear grunting in a newborn or an infant, they are experiencing some pretty good, pretty solid difficulty breathing, and that needs to be attended to. Note any decrease or increase in the respiratory rate. These are going to be indicators of respiratory distress. They're the earliest, some of the earliest indicators. Also, while you're looking, look for use of accessory muscles, the intercostal muscles between the ribs, the suprasternal and the sternal notch area of the neck, the supraclavicular and subcostal retractions. If you've got retractions in all of those areas, there is a significant distress happening, and there is a problem. I've mainly seen this in asthmatics and COPDers in extreme exacerbations of their disease process, where the airways are so locked down that they are using every muscle in their body to in their trunk area anyway, to breathe. You will hear, you may not hear anything in an instance like that where you see somebody working that hard to breathe, and you put stethoscope to chest to assess their quality of respiration or quality of ventilation. You may not hear anything. It may be what they call a silent chest, and that is a very, very, very bad indicator. That's very what do you want to call it? I apologize. Ominous sign. You want to fix that as quickly as possible. And the abdominal muscles also to assist in breathing. This indicates, again, like we said, increased respiratory effort secondary to respiratory distress. In infants and children, nasal flaring and grunting indicate respiratory distress. COPD patients have difficulty breathing. They will purse their lips during exhalation. What that does is creates artificial peak and expiratory pressure, or otherwise known as PEEP, P-E-E-P. They are creating their own pressure to help keep those airways open during that time, and that's the purpose of pursed lip breathing. Monitor the patient's blood pressure, including any differences noted during expiration versus inspiration. Patients with severe chronic obstructive pulmonary diseases, or COPD, may sustain a drop in blood pressure during inspiration. This drop is due to how much pressure is being created inside the thoracic cavity, which is limiting then blood flow to the heart. So see how these things are interconnected. This drop is due to increased pressure within the thoracic cavity, as we stated, and impairs the ability of the ventricles to fill. Thus, decreased ventricular filling leads to decreased blood pressure. A drop in blood pressure of greater than 10 torr or 10 millimeters mercury is termed pulsus paradoxus and may be indicative of severe obstructive lung disease. Is definitely worth note. Determine whether the pattern of now we're going to go into the pattern of respirations as we discussed a little bit earlier. Is it abnormal, deep or shallow, in combination with fast or slow rate? Some of the more common abnormal respiratory patterns include Kussmaul respirations. Kussmaul is deep or slow, could be slow or rapid, gasping breathing, commonly found in diabetic ketoacidosis. These are people you're going to see that are in DKA at the Kussmaul respiration stage. They are going to be very altered, if not unresponsive to you. Is something you may see with them. Cheyne-Stokes respirations. They are progressively deeper, faster breathing, alternating gradually with shallow, slower breathing, indicating a brainstem injury. This is that one I was talking about that crescendos. So you may have slow, shallow respirations, and then they're going to speed up to almost a Kussmaul, and then they're going to slow back down to slow, shallow respirations again. Then you've got biots. Biots is an irregular pattern of rate and depth with sudden, periodic episodes of apnea, including increased intracranial pressure, or I'm sorry, not including, indicating increased intracranial pressure. So these are the ones you're going to watch for herniations. You're going to see your vital signs all changing, not just respiration, but this will give you a good indication of where to start looking. Central neurogenic hyperventilation is a deep, rapid respirations, indicating increased intracranial pressure as well. Agonal respirations are a shallow, slow, or infrequent breathing, indicating brain anoxia. So this is the fish out of water type breathing, and they may not breathe but once every 10 to 15 seconds. Or we say breathing, they may not make the motions. Basically what this is not moving any air, and it's absolutely not conducive with life. Somebody in this area is going to be that is agonal respirations. They are very far down the drain. And finally, observing altered mentation may be the key in determining whether the breathing is adequate or insignificant, or if significant hypoxia is present. If the patient's mental status is not normal, you have to determine what his usual baseline is before you can make that assessment. So that's where family comes in. If this patient is on hospice care, are they normally like this? Has anything changed with their mentation? Are they normal? Are they abnormal? Is this a recent change? Is this a chronic condition, or what's going on there? So this is where history is very important as part of your assessment.